The first disease that we will be considering today is IgA nephropathy. This is also known as Buerger's disease or symphalangitic glomerulonephritis. The characteristic feature of IgA nephropathy is the presence of prominent IgA deposits in the mesangial region of the glomeruli, as demonstrated on immunofluorescence. This is one of the most commonest glomerular diseases present worldwide, and therefore is also one of the commonest causes of glomerulonephritis, resulting in end-stage renal disease throughout the world. It very classically affects young children and adults, and it has a very strong male predominance. The patients will give a classical history of recurrent attacks of hematuria. This hematuria can be microscopic or macroscopic in nature. They give a very peculiar history of episode of hematuria occurring within 1 to 2 days following attacks of pharyngitis or tonsillitis. This hematuria lasts for several days and then subsides, only to return after a few months. And because it is so associated with attacks of pharyngitis or tonsillitis, therefore it has been referred to as symphalangitic nephropathy. As far as the clinical presentation is concerned, the proteinuria is usually mild in the subnephrotic range. Some patients can present with full-blown nephritic syndrome. Some patients present with acute renal failure. Serum complement levels in these patients are always normal. The ANA is negative. And if you do the serum IgA levels, this is found to be markedly increased in at least 50% of patients. IgA nephropathy is also linked with Henoch-Schönlein purpura. These are basically two sides of the same coin. The difference being that IgA nephropathy is purely a renal disorder, whereas Henoch-Schönlein purpura is a systemic disorder. Both of these are characterized by IgA deposits in the mesangium. In addition to that, Henoch-Schönlein purpura, being systemic disorder, it involves the skin in the form of purpuric rashes, gastrointestinal tract in the form of abdominal pain, joints in the form of arthritis, and the kidneys office. What is the pathogenesis of IgA nephropathy? Now, the pathogenesis of IgA nephropathy is that following some respiratory or gastrointestinal exposure to some unknown environmental agents, the patients start producing increased amounts of IgA. Now, this is in the form of abnormal glycosylated IgA one type, which is produced by the plasma cells in the bone marrow. This has a classical feature that it is nephritogenic in nature, that is, it causes specific damage to the kidneys. So, then, as usual, when you have harmful antigens present in the body, then antibodies are secreted against this abnormally glycosylated immunoglobulin. These antigen-antibody complexes, they are deposited in the kidney and they activate the altered complement pathway, and thus they initiate the glomerular injure. The pathogenesis, there is some element of a genetic component also to the pathogenesis of IgA nephropathy, because IgA is known to occur in families as well as in initially identical cells. It is also found to occur with increased frequency in individuals who have a gluten nephropathy and in liver diseases where there is defective hepatobiliary clearance of IgA complexes. Now, then we come on to the changes of IgA nephropathy in the kidney biopsy. On light microscopy, the glomeruli, they show a variety of changes. In some conditions, they may be completely normal in nature. Others will show you mesangial widening and segmental inflammation confined only to some of the glomeruli. This is referred to as focal proliferative glomerulonephritis. In some cases, there is diffuse mesangial proliferation as well, where it is referred to as mesangioproliferative glomerulonephritis. Rarely, overt necrotizing and presenting glomerulonephritis. So this is a cartoon which depicts the changes that are most commonly seen in IgA nephropathy. So as you can see over here that there is prominent widening of the mesangium, also depicted by the wide arrow here. So each mesangial area, as you can see, is dark pink in color and has many more than 2 or 3 nuclei, which is the normal. This is another case of PS pane slide of case of IgA nephropathy. Again, you can see a marked increase in the mesangial matrix, focal increase in mesangial cellularity as well, and even a small partial fibrocellular crescent formation. But the basic diagnosis of IgA nephropathy is confirmed on immunofluorescence, where you will have a very classical, strong granular deposits of IgA in the mesangial areas. So this is I will draw, this is the glomerulus over here. So in the glomerulus, the peripheral capillary walls are usually present at the edge towards the Bowman's capsule. Now here you will find that not much of IgA is present. IgA is predominantly present in the mesangial areas. So this kind of a pattern of seen in immunofluorescence is very classical for IgA. In addition to IgA, you will have small amounts of C3, IgM, and IgG. Another classical feature of IgA nephropathy is that the lambda light chains always show a stronger intensity of staining than the kappa light chain. So when you put the two sections together, you will find that the lambda light chain has a stronger intensity of staining over kappa light chains. And normally in immunofluorescence, we grade the intensity of staining on a scale of 0 to 4. So for example, this kind of a staining is usually about 3 to 4 plus. So it's at the highest level. The EN is not very helpful in making the diagnosis. It just acts as an adjunct. This is one case of IgA nephropathy. Now this is your glomerular capillary tube, right? And if you look carefully here in the mesangium, there are these numerous dark gray electron dense deposits. This is the way in which IgA nephropathy will develop. So what is the clinical cause of this disease? The clinical cause is very variable. Many patients maintain a normal renal function for many decades. In others, there is a slow progression of the renal functions. Eventually, you want to develop chronic renal failure over a period of 20 years. In patients who the poor prognosis in the kidney biopsy can be indicated by different features, which include diffuse mesangial proliferation, segmental sclerosis, endocapillary proliferation, and tubuloinvestation fibrosis. So if any of these four features are present on microscopy, this indicates that our patient is going to have a poor prognosis and will rapidly progress to develop chronic renal failure. This is the end of IgA nephropathy. Next, we go on to the next disease, that is rapidly progressive glomerulonephritis. So rapidly progressive glomerulonephritis is a syndrome. It is not a specific etiological form of glomerulonephritis. This is characterized by a rapid loss of renal function over a period of 4 weeks, which basically means that the serum creatinine rises to very high levels within a period of few weeks. Now, as far as the other lab findings are concerned, they are typical for nephritic syndrome. As the patient will have hematuria, which is an active sediment, the urine sediment. There obviously will be azotemia, that is rise in serum creatinine, and there can be some degree of proteinuria in the urine, though this is usually in the subnephrotic. In addition, some patients can present as severe olive. The issue with rapidly progressive glomerulonephritis is that this is a very swiftly progressing disease, and if it's left untreated, will lead to death of the patient from renal failure within a period of weeks to months. The classical histological finding of rapidly progressive glomerulonephritis is the presence of numerous crescents in the glomerulus. So what are crescents? So look at this glomerulus, this dark black line. This is a Jones silver stain section of the kidney biopsy. So this dark black line, this represents the Bowman's capsule. On the inner surface of the Bowman's capsule, you can see that there is proliferation of the visceral podocytes, the parietal podocytes to form this kind of a crescentic structure, which is called as a crescent. Right? But according to definition by WHO, a crescent can only be so called when the number of layers in this crescent is more than 2 or 3 cells thick, and it partially or completely fills up the Bowman's capsule. So this is what the crescent will look like. Now, when more than 50% of the glomeruli in the kidney biopsy show presence of crescents, then this is called as a crescentic glomerulonephritis. As I said, this is not a disease-specific entity, but is a morphological manifestation of severe glomerular injury. Now, this crescent is also positive on a fibrinogen stain. So you can see that the Bowman's that you have bright green fluorescence along the Bowman's capsule. And this lighter green structure, this is your collapsed glomerular duct in the center. All this bright green fluorescence, this is part of the crescent. Now, crescental glomerulonephritis is commonly caused by three groups of disorders. One is immune complex mediated, second is quasi-immune, and third is anti-GPA mediated. Now, to distinguish between the different types of crescentic glomerulonephritis, you have to perform immunofluorescence and EM as well as some kinds of serology. Now, in the Western countries, the commonest form of crescentic glomerulonephritis is quasi-immune glomerulonephritis, right? But in our country or other Asian countries, the commonest cause is immune complex mediated glomerulonephritis, and therefore we will be discussing this in more details. So, a variety of immune complex mediated glomerulonephritis can present as a crescentic GM. So, these include post-infection glomerulonephritis, lupus nephritis class 3 and class 4, phenolphthalein, purpura, and IgA nephropathy. The less common causes include C3 glomerulopathy, fibrilary glomerulonephritis, monoclonal immunoglobulin deposition disease, and thrombotic microangiopathy. So this is the classical appearance of a post-infectious crescentic glomerulonephritis. So the white arrows, they mark the Bowman's capsule, and on the inner surface of this, you can see the proliferating parietal epithelial cells to form the complete cellular crescent. The glomerular duct is kind of collapsed in the center here. If you can see my arrow, so here this glomerular duct, which is collapsed in the center, it also shows increased proliferation as well as increase in mesangial matrix and cellularity. So this kind of a picture, this is seen in post-infectious crescentic glomerulonephritis. The immunofluorescence will confirm the findings. You have granular deposits of C3 along the peripheral capillary walls and some increases in mesangium. In addition to it, you will have immunoglobulins also, such as IgG, IgA, and sometimes IgM as well. C1q will always be negative. Now, another example of immune complex mediated glomerulonephritis is lupus nephritis class 3 and 4. In lupus nephritis class 3 and 4, again, you will see formation of partial fibrocellular crescent, as in this case, and there is marked increase in mesangial matrix and cellularity. On immunofluorescence, the findings of lupus nephritis are very classical. This shows a full house pattern. A full house pattern basically means that all the three immunoglobulins, IgG, IgA, IgM, C3 and C1q, all of them will be positive along with kappa and gamma. The pattern of positivity is a little different from the post-infectious GN in the sense that it is more prominent in the mesangium, but it is also present focally in the peripheral. So, if you have a full house pattern, deposits are in the mesangium and focally in the peripheral capillary walls, this indicates that your crescentic glomerulonephritis is because of lupus nephritis of the higher grades. We next come on to the second group of crescentic glomerulonephritis, that is a quasi-immune crescentic glomerulonephritis. Now, as the term suggests, that there is either absence or paucity of immune complexes or complements in the glomeruli, as demonstratable on immunofluorescence. So, on light microscopy, the patient will present as a crescentic glomerulonephritis, but on immunofluorescence, the glomeruli will not show you any immune complex deposit. Such cases of quasi-immune crescentic glomerulonephritis is predominantly caused by small vessel vasculitis. Depending upon the clinical presentation, the vasculitis is divided into three groups. It is called as microscopic polyangiitis, when it presents as vasculitis alone, venous granulomatosis, when it presents as vasculitis and granulomas, Church syndrome, when it presents as vasculitis, granulomas, asthma, and eosinophils. The morphological features in on-light microscopy with kidney biopsy in all the three conditions look similar. The differential diagnosis is revealed on other clinical features as well as on the serological. So the post-immune presented glomerulonephritis is basically an autoimmune disorder where autoantibodies, these are formed against ANCA. ANCA is also, full form is anti-neutrophilic cytoplasmic antibodies. These anti-neutrophilic cytoplasmic antibodies are formed against proteins in the primary granules of neutrophils and peroxidase positive granules of monocytes. There are predominantly two major groups of antigens. One is proteinase 3 or PR3 ANCA, and the second group of antigens is formed against myeloperoxidase or MPO ANCA. So how do you differentiate between these two? You can differentiate these by two methods. One is by doing ELISA test, which will tell you whether your patient is suffering from PR3 ANCA or MPO ANCA. It will also give you the numerical value of the antibody so that you can assess the severity of the disease. The other way by which you can differentiate is by immunofluorescence technique. In immunofluorescence technique, what we do is that we deposit a layer of neutrophils on a glass. Then we add the patient's serum onto that glass slide, and which is tagged with the IgG antibody to which the torclone, that is FIDC, is attached. So these IgG antibodies, they will react with the antigens which are present on the neutrophils, and these basically the antibodies in the patient's serum, they will form a reaction with the granules present in the neutrophils to form an antigen antibody complex to which the IgG labeled with FIDC is also attached. As a result of which, therefore, wherever the deposits are happening, they will light up under the immunofluorescent light. So under the fluorescent microscope, two patterns are seen. In some cases, the antibodies are deposited along the nuclear membrane of the neutrophils, which is referred to as a perinuclear pattern or a PR. Then in the second case, the granules are deposited in the cytoplasm of the neutrophils. This is referred to as a C ANCA. Microscopically, what will you see in the kidney biopsy in patients of ANCA-mediated glomerulonephritis? The hallmark of this is fibrinoid necrosis of the glomerular duct in association with presenting glomerulonephritis. So what is how will you recognize the fibrinoid necrosis? The fibrinoid necrosis is usually segmental in nature. That is, only part of the glomerular duct is involved, and the remaining part will appear unremarkable in nature. In the area of fibrinoid necrosis, the basement membrane as well as the mesangial matrix, this undergoes focal necrosis. Thus, this necrosis can be stained by Mason's trichrome stain, where it will stain red in color, in contrast to a scar formation, which stains blue in color. On PS and GSM stains, you will be able to demonstrate the disruption of their basement membranes. A very important point that you have to note is the uninvolved parts of the glomerular duct, they are unremarkable in nature. This is in contrast to the immune complex mediated presenting glomerulonephritis, where the entire glomerular duct will show you proliferation of mesangial matrix and cellularity along with endoplasmic. So this is what the glomerular duct will look like. So this is the bone. This is Jones methionine stained silver stained section for the case of post-immune presenting glomerulonephritis. This black lines represent the Bowman's capsule. And this part you can see that the basement membranes of the glomerular capillaries are broken down, and there is a pinkish orangish material which is a fibrin. And this part of the glomerular duct shows intact glomerular basement. This is another case of post-immune presenting glomerulonephritis, where it is showing you focal proliferative pattern over here. This part is unremarkable. Here, the necrotizing lesion is healed by scar formation. So this looks very much like FSGX, but you have to be there, which is why we have to be very, very careful when we are making a diagnosis of FSGX. We must exclude all other primary causes before we make the final diagnosis of primary. This is a high-part view of a glomerulus, again showing a small partial crescent here. When this part of the glomerular duct, the basement membranes are broken down. Here they are much better made. In addition to the fibrinoid necrosis that you see in the glomerular duct, there are some other changes which are also identified. And these include disruption of the Bowman's capsule, periglomerular inflammation, and granulomas with multinuclear giant cell formation. This is again a silver stain slide of a patient of autoimmune glomerulonephritis. If you trace the Bowman's capsule, then in this area where the white arrow is made, you will see that you cannot be able to see the Bowman's capsule at all. So in all this entire part, it is disrupted and broken down. In this particular problem, you find that again, it is a PS stain slide. You can't make out the Bowman's capsule. Instead, you have a extensive granuloma formation all along the glomerular tuft. But the glomerular tuft is present like in a small collapsed form in the center of this niche. So this is a granuloma formation which is present at the edge of the Bowman's capsule. Now, in addition to these stages of the glomerulus, you can also see some degree of fibrinoid necrosis and leukocytoclastic vasculitis, often involving the blood vessels, especially in the medulla. So therefore, in case of intermediate GA, you must look carefully in the medulla. You will see the fibrinoid necrosis in the medulla, in the blood vessels, and some degree of medullary hemorrhage. So this is what the blood vessels will look like. You can see this part is showing you fibrinoid necrosis, which stains red on basal striatum. So this is what the quasi-immune presenting glomerulonephritis will look like under your microscope. The third type of presenting gene is anti-GBM mediated glomerulonephritis. So here, this is again an autoimmune disease where antibodies are formed against the anti-GBM glomerular basement membrane. So these autoantibodies, they develop against the alpha-3 gene of the type of collagen in the vascular basement membranes. You can demonstrate these anti-GBM antibodies by performing an ELISA test, when you will get also a numerical value, so you can assess the severity of the disease. On immunofluorescence, anti-GBM glomerulonephritis shows a very classical feature in the form of linear localization of immunoglobulins along the glomerular and the pulmonary capillary. Now, this anti-GBM glomerulonephritis is one of the most destructive forms of glomerulonephritis and has a very poor prognosis. Patients usually present with severe renal failure. In a bimodal age of presentation, they can present, one group presents in adolescents and young adults, and the second group presents around the 60 years. The anti-GBM disease can also involve the pulmonary capillaries, in which case the patient can also show features of hemoptysis. The microscopic features will be similar to those of ANCA-mediated glomerulonephritis. It's a presenting GN. This part is showing you some degree of necrosis of the glomerular tuft. This part is fine. Again, you see fibrinoid necrosis where the silver is broken. The glomerular basement membranes are broken down on silver methylene stain. There is disruption of the Bowman's capsule, and you can also see formation of granulomas along with multinucleate giants. The diagnostic feature of anti-GBM glomerulonephritis is, however, seen on immunofluorescence. On immunofluorescence, you will see a very strong linear staining for IgG along the glomerular basement membrane. If you look carefully, this is like a single line. You will not see the classical granularity that you see in an immune complex mediated. Right? And this intensity of staining should be at a scale of 3 to 4 plus. Right? I already explained to you that in frozen sections on immunofluorescence, we grade the degree of immunofluorescence on a scale of 0 to 4 plus. So to make a diagnosis of anti-GBM mediated glomerulonephritis, the amount of staining, the intensity of staining should be at least 3 to 4. Right? This kind of a pattern is very classically confirms the diagnosis of anti-GBM mediated. The patients have a very poor prognosis. In order to make these patients survive, you have to give intense immunosuppression. You also have to do plasma pheresis depending upon the serum creatinine levels at the time of initial diagnosis. But even after that, many patients do develop chronic failure and eventually they will die from it. So this finishes off with your presenting glomerulonephritis. Then we come on to hereditary nephritis. Okay? So these are a group of renal disorders of glomerulonephritis which are congenital in nature. The most important member of this group is Alport syndrome. This Alport syndrome is a primary basement membrane disorder. If the patients usually present as the clinical symptoms are very mild, this present as frequent episodes of gross or microscopic hematuria. Nothing else. The serum creatinine levels will be normal, but gradually as time passes, the serum creatinine starts to inch upwards, and the patients start developing progressive nephritis. Eventually, go on to develop chronic kidney. There is some degree of subnephrotic vein proteinuria. In addition to that, these patients have an associated deafness as well as ocular abnormalities. So when the patient presents with hematuria in association with deafness and ocular abnormalities, you must do the kidney biopsy for electron microscopy to check the presence of Alport. What is the pathogenesis? How does Alport syndrome develop? Now, the glomerular basal membrane normally is composed of heteroprimers of alpha 3, alpha 4, and alpha 5 type 4 collagen. This type of collagen, this is present not only in the glomerulus, but also in the lens and the cornea, and in all the three organs. It is extremely important for the normal functioning of these organs. Now, in patients of Alport syndrome, at least in 80 to 85% of these patients, they show a genetic mutation of in the gene which involves which indicates formation of laying out of collagen 4A5. This is an X-linked disorder, and because of mutation in this particular gene, the alpha chain, the heterotrimer of the alpha chains, this does not form properly. There is defective heterotrimer assembly, and therefore since the collagen, this forms a predominant component of the basal membrane. The glomerular basal membrane gets damaged, and this presents as Alport. So when you perform the kidney biopsy in these patients, the glomerular or light microscopy will appear unremarkable. The only thing that you might see is some degree of foam cells in the interstitium because of accumulation of neutral fats and polysaccharides because of the mark protein. In the later course of disease, obviously the patient progresses to all features of chronic kidney failure in the form of vascular sclerosis, tubular nephropathy, and infestation. Can you all hear me, or is there any problem in the audio? I'm getting a message that okay, thank you so much, Dr. Shankar. I'll continue then. So this is the microscope, this is the EM photograph of Alport syndrome because the diagnosis of Alport syndrome, this is made by the electron microscope. So normally, you've seen many micro photographs, you know that some people are having a problem. Let me just go back a little bit. So I've closed some of my other presentations that were open, and I hope that this will be better now. Okay, so this is the glomerular basal membrane, and this shows this is not a single line that you normally see, but you can see there's something that there's areas of dark and light. It has a very classical basket weave pattern, as it is so called. The glomerular basal membrane, as you can see, is obviously markedly abnormal and shows splitting and lamination. This is called as a classical basket weave appearance. So this is the diagnostic for Alport syndrome. You can also confirm the diagnosis by performing immunofluorescence stains for the different using different monoclonal antibodies against the different subcomponents of the collagen type 4. That is, you have antibodies directed against alpha 3, alpha 4, and alpha 5 chains of type 4 collagen. And when you apply these on the frozen sections of the patient with Alport syndrome, They will not combine with the glomerular membranes, and the stain will be negative. So this will confirm that this patient has IgA. The second hereditary disorder that we need to consider is thin basal membrane disease. Now, this thin basal membrane disease, this is a very common hereditary disorder in which the patient is absolutely unremarkable, except for the fact that he might be showing some degree of hematuria, which is usually discovered on a routine urine examination. But this is a familial condition, so the patient might give you a family history that there are other patients in his family who have urine disorder. To perform the electron microscopy and we measure the thickness of the glomerular basal membrane, you will find that it is much thinner than normal. The normal range is 150 to 250 nanometers. Again, this anomaly is caused because of a mutation in the genes encoding alpha-3 and alpha-4 subchains of triphosphorin. So this is what the EM will look like. Now, this is a normal glomerulus. You can see the basal membrane. This is what it looks like. But in this particular case, you see the glomerular basal membrane is markedly. So this is a case of thin basal membrane disease. Next, we come on to Fabry's disease. The Fabry's disease is an X-linked recessive lysosomal storage disease, which is caused by deficient activity of the lysosomal enzyme alpha-galactosidase A. Right? As a result of deficient activity of this enzyme alpha-galactosidase A, there is accumulation of various lipid products which are I don't know whatever it is. Gb3. The Gb3 accumulates in many cells, particularly in the renal epithelial cells, endothelial cells, the pericytes, the vascular smooth muscle cells, the cardiomyocytes, and the neurons of the autonomic nervous system. As far as the kidney biopsy is concerned, all that you will see on the right microscopy is that the glomeruli enlarged in size. The distal epithelial cells of the podocytes, they are markedly enlarged, they are prominent, and they are distended with a foamy appearing vacuoles. Right? So this is what they will look like on PS stain. So this is the glomerular Bowman's capsule. These are glomerular capillary loops, and the outside of the Bowman's glomerular basal membranes, you see these cells which have a foamy cytoplasm. And this foamy cytoplasm, when you do EM, before we see the sections under the electron microscope, we cut them semi-thin sections and we stain them with toluidine blue stain. So this is one example of a semi-thin section stained with toluidine blue. This is your glomerular capillary loop, and this is the podocyte, and you can see that this cytoplasm is packed with spherical structures which are dark blue in color. Now these, when you examine this photograph and these podocytes in the electron microscope, you'll find that they will show you concentric rings. So these structures, they are called as zebra bodies, and they are confirmatory for the diagnosis of Fabry's. Next, we come on to chronic glomerulonephritis. Okay, so I have already discussed this concept earlier, that any kind of glomerulonephritis, as we know that in the kidney, once the glomerulus is lost, it never really comes back, right? So therefore, eventually, when you have loss of glomeruli because of any glomerulonephritis, this will damage the glomeruli. In turn, the tubules which are derived from these glomeruli, they will also undergo atrophy. This will then cause some stress on the remaining viable glomeruli, which will undergo hypertrophy. They will overfunction. When they overfunction, then the intravascular pressure within these hypertrophic glomeruli rises, which causes endothelial damage and eventually damage to the splenic. So once damage to the kidney starts, it kind of becomes inexorable. The cycle keeps on progressing until finally end-stage renal disease happens. And the only thing that the nephrologist can do is to decrease, the rate of progression of this glomeruli. Right? So any kind of disease can cause glomerulonephritis. This includes post-streptococcal, dysentery glomerulonephritis, membranous nephropathy, focal segmental glomerulosclerosis, FDJ, and IgA. Now, in some cases, however, sometimes the chronic glomerulonephritis this suddenly presents. It may have been going on at a low-grade level, which was unrecognized, and finally, when the creatinine rises to very high levels, then the patient comes to the nephrologist, and then he realizes by that time that the creatinine is very high, and he can, and even if he does the biopsy, he will not be able to find the primary cause of the lupus. On gross microscopy, what do the kidneys look like? They are symmetrically, they are small in size, they are contracted, they have a diffuse granular cortical surface. When you cut this, the cortex is thinned out and there is loss of corticomedullary junction with increase in peripelvic fat. So this particular gross specimen will be shown to you in your tutorials. You will know that this is a case of chronic glomerulonephritis. On microscopy, you will find that many of the glomeruli, they have undergone sclerosis. Even this glomerulus that is present is hypertrophic in nature, it's not really viable. There is the tubules also show large areas of tubular atrophy. There is interstitial fibrosis, and there is a mononuclear inflammatory cell infiltrate in the interstitium. The blood vessels will show you marked thickening of the media, which is referred to as arterial and arteriolosclerosis. Now, most cases of chronic glomerulonephritis, they present insidiously and slowly progress to renal insufficiency. Ultimately, the patient becomes dialysis dependent and may either die from uremia or will require renal transplant to be able to survive. And this leaves us with the final part of this lecture, that is diseases involving the blood vessels. And the diseases involving the blood vessels are basically divided into two types: benign nephrosclerosis and malignant nephrosclerosis. The benign nephrosclerosis is defined as sclerosis or hardening of the renal arterioles and the small arteries. The blood vessels will show you thickened walls with narrow lumens, and which will in turn produce focal hysteria of the parenchyma being supplied by these. This classical appearance is called as hyaline arteriolosclerosis. So basically, there are two important changes in this. One is that the media and the intima are thickened as a response to the hemodynamic change, and secondly is that because of damage to the endothelium, there is extravasation of plasma proteins through this damaged endothelium to deposit in the arterioles, reducing the hyaline deposition in these arterioles. Okay? So because of the hemodynamic changes, some of the glomeruli will show, some of the blood vessels will show you medial and intimal thickening, whereas others will show you hyaline deposition in the arterioles. On gross morphology, the kidneys are either normal in size or they are moderately reduced. The cortical surface has a fine, even granularity that resembles grain leather. On microscopy, the blood vessels will either show you homogeneous hyaline thickening of the walls, which is referred to as hyaline arteriosclerosis, or other vessels will show you marked thickening of the media, resulting in narrowing of the vessel wall. This is what they will look like. So see these vessels, they are showing you marked concentric thickening of the wall of the arterioles, whereas here you have these prominent hyaline material deposited in the walls. Both these changes will lead to a reduction in the lumina of the blood vessels. In this particular section, you can see that the hyaline arteriosclerosis is very common. So this renal lesion is usually benign and does not cause severe damage to the kidney in the form of renal insufficiency or uremia. However, all patients will show you a moderate reduction in the renal blood flow. The glomerular filtration rate will remain either normal or only mild. And the only prominent change that these patients have is a mild degree of protein. So as long as you control the intravascular pressure by giving ACE inhibitors, this disease does not progress and the patients will do better. On the other hand, malignant hypertension, this is markedly damaging to the kidney. Malignant hypertension is defined as blood pressure which is higher than 200 millimeters of mercury in the systolic for the systolic blood pressure and more than 120 millimeters of mercury for the diastolic. This occurs very rarely, only a few percentage of cases, where it can occur either de novo without any pre-existing hypertension, or it will appear suddenly in a patient who had only a mild hypertension. As a result of the sudden shooting up of the blood pressure, the small blood vessels, they are obviously damaged. Because of this, the damage of the endothelial cells, there is increased permeability of the small vessels to fibrinogen and other plasma proteins. Endothelial damage occurs, focal like death of the cells of the vascular wall happens, and facial deposition. This is what it looks like. The blood vessel walls, they show you marked fibrinoid necrosis, which is bright red in color, surrounded by some polymorphs and inflammatories. If you look carefully, this is your glomerular stuff, this is the Bowman's capsule, and the genes that you are seeing is in the aftermath. And you can see a very prominent concentric hyperplastic arteriosclerosis, which leads to almost complete blockage of lumina of the kidney. The gross picture in case of malignant hypertension is very classical. The kidney is usually normal in size. They show numerous pinpoint hemorrhages on its surface, which is referred to as a free little. So these numerous pinpoint hemorrhages are basically caused by rupture of arterioles or glomerular capillaries just beneath the capsule because they have a very high intravascular blood pressure. On microscopic examination, we obviously see fibrinoid necrosis of the arterioles and hyperplastic arteriolosclerosis with a classical onion skin-like appearance. This leads to marked narrowing of the arterioles and obliteration of the lumina, and very often you can see microthrombi. This is what the vessels will look like. Markedly, this fibrinoid necrosis. Stains red on fibrin stain. And there is thrombi formation, which will lead to obstruction of the stain. Now, cellular glomerulus will show you hypertrophy related changes. As far as the clinical features are concerned, the systolic blood pressure will be more than 200 and the diastolic blood pressure more than 120 nanometers of mercury to classify as malignant hypertension. The patients will have edema, retinal hemorrhages, encephalopathy, cardiovascular abnormalities, and bleeding. And sometimes you can have hypertensive crisis characterized by episodes of loss of consciousness or even this syndrome is a true medical emergency and it requires aggressive and prompt antihypertensive therapy to prevent development of irreversible degenerations. The mortality rate is very high. Within almost 50% of patients will expire within the first 3 months of presentation of the disease, which progresses to 90% within a year. Whatever few are left behind, they will eventually develop either chronic renal failure, cerebral hemorrhage, or cardiac. So that finishes off my 3 lectures on glomerulonephritis and the different types of diseases involving the kidney, including infective and autoimmune or congenital. I hope that I was able to explain things to you, and you will not find things that kidney pathology was very difficult. If you have any questions, please do put them forward. Okay, so Dr. Arachi wants to see the bodies again. Okay, let me look to that. Okay. So this was the case of Fabry's disease. So this is the light microscopic picture of the glomerulus, which shows a lot of foraminus in the photocytes. And this was the semithin section. You can see this is the glomerular duct over here, and the photocyte is markedly expanded with presence of these dark blue circular structures. And these when you examine under the EM. You see these? So this is your glomerular duct here, the glomerular capillary loop, and these cells on the outside, these are the photocytes. So in the cytoplasm of these photocytes, you will get these concentric ring-like structures. These are called as zebra pods, right? I hope now it is more clear to you.